And my topic today is managing conduction disturbances after TAVI. And to understand why this remains an important issue in TAVI patients, we have to realize that conduction defects are already existing in these patients at baseline before they undergo the procedure. And the bundle of his traverses the membranous septum towards the LVOT, running over the crest of the intervertebral septum to give rise to the left bundle branch, and this makes the his bundle and its left branch vulnerable to mechanical injury during the various steps of the TAVI procedure. And this illustration shows you how close the distance is between the point where the his bundle bends over the crest of the intervertebral septum, giving rise to the left bundle branch, and the distance between this turnover in the course of the his bundle and the annular plane is determined by the height or the length of the membranous septum. And therefore, at least theoretically, the shorter the membranous septum, the closer will be the relationship between the annular plane and the conduction system. And indeed, autopsy studies have confirmed that the conduction system is exposed to compression, to hematoma, in addition to the underlying age-related degenerative changes. Therefore, it's not surprising that conduction disturbances remain one of the most common post-TAVI complications, although the rate varies between different platforms and different iterations. Most platforms still show a pacemaker rate of 2 digits, with very few exceptions. Probably accurate neo may be associated with a lower rate, as well as the later series of the Sapien 3 and Sapien 3 Ultra. The same applies to new onset left bundle branch block. So it's not only the requirement for a new permanent pacemaker, but also the development of new left bundle branch block, which remains quite common. We need to bear in mind that the vast majority of these conduction disturbances arise very early during the procedure or in the few hours thereafter. Of course, some other events may take over the next few days, but the rate is much lower than the earlier phase. It is also imperative and also a bit counterintuitive that many of these conduction disturbances vanish over time. So almost 1/3 of left bundle branch block is not there anymore at 1 year. And what is really funny, really interesting, has to be taken into consideration is that so many of our pacemaker recipients are not pacemaker dependent in the intermediate term after the procedure. And then comes the question, does it matter? So I have saved my patient's life. I know if I leave him or her with severe aortic stenosis, she will die in a couple of months. So I will save her life, and in return, she will have to pay the price. The price is a pacemaker. What's the problem? What's the big deal? And then we run so many studies trying to explore whether pacemakers are associated with worse outcome after TAVI. And in my humble opinion, this is really artificial. This dilemma is artificial. Pacemakers portend worse prognosis on the long term. So if you wait 5-10 years, pacemakers are not so friendly or no. Of course, they will give important benefits, but also they will beget some important downsides. And all we need is more time. So if we wait 10 years, we will see the impact on synchrony, on tricuspid valve, on the right heart, on lead complications, including device-related endocarditis and so on. And indeed, at least left bundle branch block is now clearly linked to worse outcome after TAVI, not only in terms of the requirement for pacemaker in the near future, but also in terms of mortality, rehospitalization, and even ejection fraction deterioration over time. And a recent meta-analysis has given a more or less convincing conclusion that both new permanent pacemaker as well as new left bundle branch block are associated with worse outcome. So what are the risk factors or predictors? I myself prefer to use this scheme of classification, patient-related risk factors, device-related risk factors and technique-related risk factors. And besides these causative factors, there is some confounding or contributing factor, that is the threshold of the operator to implant a permanent pacemaker. Some operators tend to implant the pacemaker at a low threshold to facilitate earlier patient discharge. I don't want my patient to remain under surveillance, under monitoring. No, I'll put just a pacemaker and send the patient home. And among the patient-related risk factors, the anatomy plays a role, the landing zone, its shape, the calcium load and distribution, as well as the anatomy and the function of the conduction system. For example, if the patient already has an underlying AV conduction delay or a right bundle branch block, then the development of left bundle branch block after the procedure will end up with a complete heart block. Regarding device-related risk factors, of course, the platform itself plays a role. Mechanically expandable devices, for example, the Lotus valve, which is otherwise a superb device, has been associated with exceedingly high rates of pacemaker requirement. Device size per se, as well as in relation to the LVT, the extent of LVT oversizing may also play a role. And the technique-related factors are important, especially implantation depth. A deeper implant will bring my device closer to the conduction system, and a shallower implant will probably spare my conduction system. Balloon pre-dilatation has also been linked with conduction disturbances, and some studies have also confirmed the relationship between post-dilatation and conduction disturbances. And the beauty of this classification is that it automatically translates into non-modifiable factors, relatively modifiable factors, and more or less totally modifiable factors. These are again the list, and the red boxes on the right shows you the weight of evidence supporting each of these risk factors. And again, some authors like to classify these risk factors into clinical or demographic, EKG or ECG related, anatomic, and procedural. And if we go to the procedural risk factors, because they are more or less modifiable, and this is where we can modify the risk, the THV platform, as mentioned earlier, has an important role with the among the commercially available devices in Egypt. Maybe Accurate Neo has a very good profile in terms of pacemaker requirement. Sapien 3 also has a good profile, especially if we stick to the modern implantation techniques. And self-expandable devices, although have witnessed a major improvement in the pacemaker requirement rate, the rate remains considerable in the range of 2 digits. One of the most important modifiable factors that we can manipulate in order to reduce our pacemaker requirement rate is the implantation depth, and this has already been confirmed in some interventional studies that try to optimize the implantation depth and hence improve the pacemaker requirement rate. And the interesting part in that trial, which was Advanced 2, it was a two-way interventional trial. They were trying to reduce the pacemaker rate by reducing the implantation depth and sticking to the guideline indications for pacemaker implantation. So you try to improve your procedure and you stick to the guidelines when you decide upon whether your patient will need a pacemaker or not. And fortunately, we eventually had very clear recommendations from the very recent pacing guidelines about the indications for pacemaker implantation in TAVI patients. Among the modifiable factors, which is namely the implantation depth, actually the majority of the data we know is related to the self-expandable platform. But indeed, this applies to almost all platforms. Even for the balloon expandable device, if you aim towards a relatively shallower implant, then you will need the pacemaker less often. And it has been recently suggested that the use of the cusp overlap technique will help us even more and more improve the implantation depth and taking our devices away from the conduction system. And the idea is that the cusp overlap view foreshortens and elongates the LVOT and takes the non-coronary cusp on one side of the screen, and then you can focus on the implantation depth in relation to the non-coronary cusp where the conduction system is more or less located. And indeed, a very recent study has confirmed that the systematic implantation in the cusp overlap view or overlay view will help you improve your implantation depth and hence decrease the pacemaker rate. I'll have to skip a couple of slides in order to save some time. This slide eventually summarizes the procedural step that you may take into consideration in order to decrease the rate of conduction disturbances. Consider that TAVI platform with lower risk when you anticipate that the conduction disturbance risk is higher. A patient with right bond branch block at baseline has a high risk of developing complete heart block. Then don't move to take a device with a known high rate of pacemaker. Avoid LVT overstretch. Continuous ECG monitoring during the procedure if you anticipate that the patient is at risk. Venous access and temporary pacemaker is a routine. Consider avoiding pre-dilatation when possible if you perceive that your patient is at increased risk of conduction disturbances, and aim to minimize depth of valve implantation. I think I need 2 minutes. عشان قلت 2 كنت قلت 3. طيب. Can we modify the risk? Actually, yes. And a recent study, the MEDS approach, tried to systematically improve the procedural factors that are related to the pacemaker rate. And indeed, it did succeed in achieving that. So they realized that right bond branch block and a membranous septal length that's shorter than 5 centimeters and a deeper implant and a larger device, these are the most important factors. And then they developed this model and moved to improve these factors. So whenever you have a patient with a right bundle branch block and a short membranous septum, then you try to tailor your implantation depth to meet this demand. So the shorter the membranous septum, the shorter the distance between the inflow and the conduction system, then you should aim for a relatively even shallower implantation. And if you have a relatively long membranous septum, then a more or less deeper implant may be forgivable. So what about the peri-procedural management of conduction disturbances? Should they develop already? So you have already a conduction disturbance that has developed after the procedure. How do we deal with this? There has been a couple of documents trying to systematically approach these conditions. One was developed by the JAC Scientific Expert Panel in 2019, and it suggested a couple of flow charts. And then in 2020, the ACC Expert Consensus Decision Pathway has been developed to tackle these cases. And I will just quote a couple of sentences here. They tell you that among the suggested pre-TAV or plan for increased risk patients, so you identify that the patient is at increased risk, what should we do? So counsel the patient. So in general, we should counsel our patient about the common complications at least. And if you perceive that this particular patient is at exceedingly high risk of permanent pacemaker, then it's really imperative to explain and give enough details about this. Schedule TAVR at a time when pacemaker implanters are available. And consider implantation of a secure pacing lead peri-procedurally. As I've mentioned, we very recently had very clear, to-the-point indications in the pacing guidelines. They're very to the point, and I will not go through them. You can refer to the pacing guidelines of the EC published in 2021, and they will take you there. So my take-home message is that pre-TAVI, please identify those at increased risk of conduction disturbances. Intra-procedural, Please exercise pacemaker sparing strategies we have been through. And post-TAVI, identify whom to keep an eye on. Some patients deserve a closer follow-up and closer surveillance, and reserve permanent pacemaker to those who really deserve it. Please adhere to the guidelines. Thank you very much.